We thank you very much for joining us. My name is Diane Henk, and I'm with the Office for People with Developmental Disabilities. As you may know, New York State is committed to limiting to the greatest extent the use of hands-on interventions or isolation as means of managing behavior for individuals who are served in our service systems. In 2013, Deputy Health Secretary Courtney Burke convened a multi-agency work group on this issue. And as a result of that work group, 4 of our agencies have continued to partner together on this initiative. They are the State Education Department, the Office of Mental Health, the Office of Children and Family Services, and the Office for People with Developmental Disabilities. And since 2013, each of these agencies has joined in creating work plans and implementation plans to focus on this issue within our respective service systems. Now, more information on that initiative was covered in the first webcast forum that we did in March of this year. And you can view that webcast from the OMH website where we have it posted for people to view. So I won't go into a lot of detail on that now. But I can say that through that forum, which included providers from across all 4 systems around the state, we found that there is significant interest in this issue. And we knew that we could move forward with a learning collaborative with our provider systems and other stakeholders to look at the issues of restraint and seclusion. One of the other things we learned from that forum is that there was tremendous interest in the issue of trauma-informed care. That leads us to our presentation today. I want to thank the Office of Mental Health and specifically Laura Mandel, who has really led the effort to put this day together in this presentation, for putting this together for us today, and it should be very informative. We want to make today as interactive as possible, so if we can advance to slide 1, I'd like you all to be able to see the email address. If you are watching via the internet and would like to email us a question or comment at any time during this presentation, please do so. We will be monitoring all those comments and questions, and we will have time at the end of the presentations to address as many of them as possible. So now, without further ado, I'd like to introduce the moderator of our program today. Please welcome Tricia Harnett. She is the Director of the Office of Quality Improvement within the Office of Mental Health's Division of Quality Management. So Tricia, I'll let you take it from here and introduce our panelists. Thank you.
Thanks, Diane. I will be moderating the webcast today. We have a very informative agenda planned for the next 2 hours. We'll be hearing from panelists on the prevalence of trauma and trauma-informed care, youth testimony on the experience of trauma, and of being restrained and secluded. It really is a privilege to sit with this panel of esteemed guests. First, I'd like to introduce you to our panelists, and we'll give you some of their bio, but certainly their full bios will be on your screen. David Robertson is a mental health program specialist at the Office of Mental Health. He's been with the Office of Mental Health for almost 48 years. He currently works in the State Operations, Children and Adult Services Division, and is an OMH Crisis Prevention Master Trainer. He has been a lead participant in the Office of Mental Health's 4-year SAMHSA grant, Positive Alternatives to Seclusion and Restraint, and has presented numerous trainings on trauma, trauma-informed care, sensory modulation, comfort rooms, and NASHBID's 6 core strategies for reducing the use of seclusion and restraint. He co-authored the recently published article on the results of this initiative. David, welcome. Stephanie Orlando is the Executive Director of Youth Power, building upon her personal experience of having received children's mental health, special education, and residential services. She began her work with youth peer advocacy in 1998 in Buffalo, New York. In the years since, she has become a nationally recognized advocate for youth with disabilities. She has received numerous awards for her work. In 2005, she started working for Families Together in New York State as the statewide youth coordinator. By 2007, she and a few other young leaders had founded the Youth Power Network. In 2012, Ms. Orlando was appointed by President Obama and confirmed by the U.S. Senate to the National Council on Disability through November of 2014. Stephanie, thank you for being here. DeMonica Jeffries is the Hudson River Regional Youth Partner for Youth Power. DeMonica spent most of her life in foster care, where she came to understand the importance and necessity of youth voice in all child-serving systems. While in foster care, DeMonica was involved in projects to increase widespread youth voice and participation. DeMonica has touched many systems and advocates for a better tomorrow for all youth. Ms. Jeffries, thanks for joining us. Before I hand things over to our presenters, I'd like to remind you that if during the presentation you have questions or comments, please send them to us using the email address forum@opwdd.ny.gov. We'll have a chance to address your questions later in the program. David?
Thank you. This part of the presentation is from a program that was developed by Dr. Glenn Sachs, originally from Boston University Medical Center. I believe he's down at Columbia University right now. And he believes that when we're serving people who've been traumatized, we really have to have them treated right, ethically, to be true to the Hippocratic Oath. And first, that dictum saying, first do no harm. So people with trauma histories may have a number of problems resulting from their traumatic experiences, including difficulty in controlling their behaviors. So one important task of the treatment is to avoid any intervention that can be re-traumatizing or just basically doing more harm. As children walk the pathways to their futures, and parents guide those pathways, and they clear them out, and they take some of the obstacles out of the way, just like that, for the people we serve in our programs, we need to clear those paths for their futures and clear out those issues that might be traumatizing or re-traumatizing. Staff basically have the responsibility of helping people that we serve heal, recover, find and believe in and capitalize on their own resiliencies. So what is trauma? NASHBID in 2006, NASHBID is the National Association of State Mental Health Program Directors, defined it as the experience of violence and victimization, including sexual abuse, physical abuse, severe neglect, loss, domestic violence, and or the witnessing of violence, terrorism, or disaster. The DSM-5 in 2013 talked about trauma including direct experience of the traumatic event, witnessing the traumatic event in person, learning that the traumatic event occurred to a close family member or close friend, with the actual or threatened death being either violent or accidental, or experiences firsthand repeated extreme exposure to adversive details of the traumatic event, not through media, pictures, television, or movies, unless work-related. I think it's important to recognize that in people who have experienced trauma, it's not only those that have experienced it, but those that have witnessed it. You heard that twice in the definitions, both from DSM-3 and from NASHBIT. You don't actually have to experience trauma to have trauma affect you. So we want to remember that witnessing of trauma is quite a powerful thing. The prevalence of trauma in the United States is quite huge, and there's been a lot of studies done. We've got some studies here in 1999, 2001, 1998, but you see that a huge number of people in the United States have been suspected or actual victims of trauma, and I'm not going to read, you can read them across the screen yourself. And we talk about the prevalence. Again, a number of surveys have been done on this, and you can go anywhere from 80 to 98%. They're all going to come up in those at least high figures of the people in public health who receive public mental health services have experienced trauma in their life. It's a huge problem, and it affects a number of people, and the vast majority of people that we serve. So what does it tell us? It says that the majority of adults in children's and psychiatric treatment settings have a trauma history. Maybe we should be thinking that everyone has a trauma history, whether or not we know it or not, because I think thinking about it from the perspective of maybe universal precautions, we use that for infection control. Why wouldn't we use it for trauma when we see the prevalence of it this high? A sizable percentage of people with substance abuse disorders have traumatic stress symptoms that interfere with their ability to maintain stability, and a sizable percentage of adult and children in the prison or juvenile justice systems also have trauma histories. So basically, trauma is present across the world. Massachusetts did a study, and they did a study of their own mental health workers in their psychiatric settings, and found that 25% of workers had symptoms of trauma. That's people who would admit to it. My guess is that figure is much, much higher. So we learned from what we call the ACE study, the Adverse Childhood Experiences Study. Back in 1995 through 1997, conducted by Kaiser Permanente, led by Dr. Vincent Felitti, did what we call the Adverse Childhood Experiences Study, where they took more than 17,000 mental health organization members undergoing physical examination, provided detailed information about the childhood experiences that they experienced in childhood, including abuse, neglect, family dysfunction. They had 10 areas where they wanted people to respond in: recurrent physical abuse, recurrent emotional abuse, contact sexual abuse, alcohol or substance abuse in the household, an incarcerated household member, a family member who's chronically depressed, mentally ill, institutionalized, or suicidal, mother is treated violently, one or no parents, physical neglect, and emotional neglect. The results of those studies determined that the more adverse traumatic a childhood, the higher the health risk. Brain development, cognitive and emotional abilities are influenced by trauma. This promotes high-risk behaviors such as substance abuse, sexual acting out, and in turn increase health issues which can lead to early death. In addition, just being in the mental health system can produce circumstances that have a long-term health effect on our well-being. It's important to recognize that it is not the severity of the trauma that is the variable of how a person might respond to the trauma that they experienced. It is truly the individual response to that trauma. There was a study done with children who had severe burns, who were traumatized as a result of very severe burns. And this particular slide shows it. On the left side, it talked about how much trauma the child was experiencing when they entered the treatment facility. And on the right side of it, it shows that how much trauma they were experiencing 3 months later after receiving both physical and psychological treatment for that trauma. If you look at the slide and the graph on the slide, you'll see that the points begin at a variety of areas where when they first entered, they had a variety of different trauma symptoms. If the line went down, they got better. If the line went up, they got worse. If the line stayed across, they stayed exactly the same. Look at the direction of all the lines. And what it says is each of these persons experienced the same kind of severe burn trauma that they each did, but the individual responses have just tremendous differences. And what we take from that is it's the individual that's the variable in experiencing the trauma. And I think mental health care workers have to look at when we see histories and we read something and we think, well, that doesn't appear to be such a severe trauma in our own mind. It's not the trauma. It's the individual person's response to it. So one person may experience a very severe trauma and it minimally affects their life. Another experiences perhaps a much lesser degree trauma, yet it's life devastating to them. Some more studies were done on persons who have experienced trauma in their life. This particular slide shows an MRI. On the left, you have a normal 11-year-old, and on the right, you have a maltreated boy with chronic PTSD. And we do a comparison of the MRIs of the brain. And there are some significant differences in it. If you look at the left and the right, and you look at the two, you see the area that goes around the outside of the skull is a thinner white line in the left side and a thicker white line on the right side, the person who was traumatized. That is space. All right, that area of white is space, which means the brain has actually shrunk. The cerebral cortex of the brain, in this particular case, has shrunken down, and there's a crease of space between it and the cranium itself. If you also look at the triangular, black triangular, there should be 3 of them in the middle of the MRI scan. Those are the ventricles in the brain. Notice how perfect triangular they are on the left, non-traumatized individual side, but how elongated and opened up they are. They have actually expanded. They contain cerebrospinal fluid, and they have actually expanded at the expense of brain tissue. So when they're expanding from that perspective, we're seeing that there's actually damage that's occurring to the brain inside. So as a result, we know now that the experience of trauma, both psychologically and physically, affects an individual person. So what we've surmised now from this is that the brain chemistry is somehow altered and affected by trauma. And what it does is to put these individuals into an immediate flight or fight kind of mechanism. They experience a heightened sense of fear or danger continually in their life. These studies have really shown, and I'm going to explain a little later how this mechanism might work. All right, let's just, if we look at example of Robert. Robert was a 22-year-old man, had a history of severe childhood physical abuse. He displayed a very aggressive behavior. He was on a psychiatric ward. He was having a pretty good day. He's sitting in the day room watching TV. Everything was going well. A couple employees walked up behind him, began having a discussion amongst themselves. I think it was about a football game. And Robert, in his mind, heard a very demeaning statement come from one of them, and it was from the voice of his stepfather was a very abusive man who frequently went out and got very drunk at night and would come home and would be mumbling to himself and then beat the crap out of Robert. Robert sensed a feeling of fear in this point, and something happened. And I think this what the slide now is showing us is he was in a calm, continuous, engaged state, and all of a sudden he hears the voice of his stepfather, and he immediately attacks the two people that were talking behind him. Now, what happens when you attack two employees in a psychiatric facility, right? You get restrained. So when he got restrained, Robert is no longer fighting. He becomes extremely fearful. He's fighting for his life, but he's not fighting the two employees. He's fighting his stepfather. He has really dissociated back to the original trauma. It's important, and I'll talk about this a little bit later in the presentation, that staff members recognize that what we say, when we say it, how we say it is important in all aspects of our treatment. Simply bringing Robert back to the present, I'm David here, it's all right, you're in the day room here, we're trying to help you through. That might have been extremely helpful when we use kind of grounding statements, but that didn't happen. Another example that we have is Talia. She was a 12-year-old girl with a history of sexual abuse. She was teased by a boy in school. Actually, she's sitting next to a boy in school who made a comment about her breasts. I think he says, "Are they ever going to grow?" And she immediately felt a sense of shame come over her. And then that sense of shame became even worse, and it was like, remember, she had been raped before, had a history of this abuse. It was almost like she was feeling like this was already happening again. So she immediately left the classroom, and when she got out of the classroom, it was even more fearful. It was almost like somebody was after her and was going to do this one more. So she ran home quickly, went to the medicine cabinet, grabbed the razor blade that she had conveniently stored in place when and Mom was home, fortunately. And she was readmitted, and as a result, but we see what happens here is you're doing okay, and something happens that triggers a memory of a very traumatic event. That sets a whole cascade of things that go on, and the person now reacts in a way that perhaps might be aggressive or self-abusive to themselves. So we look at the parameters that actually happen when we go from a calm and steady state to an agitated and out of control or even dissociated state. It begins with our feeling, what we're feeling. I'm not feeling comfortable, I'm not feeling safe, I'm feeling fearful, right? That changes the way I'm thinking. I need to protect myself. I can't let this happen, and behavior immediately follows through that. I might attack someone, I might attack myself. My sense of self now becomes in question, my consciousness of where I am and what am I. And actually, the traumatic events of the past come to the future, and the person dissociates from that perspective. All it takes is a triggering event for this to happen. So when we talk about what we have to do about it in our clinical areas and where we're going to do, we need to try and build what we call a wedge of cognition between that stimulus, maybe the boy who made the comment to Talia, or maybe the employees who are just having a conversation amongst themselves, recognize that's a stimulus, and we need to build something when a person is triggered that we get them to cognitively restructure in their brain through either some neuroregulatory intervention that we've taught them to do, right, and build upon their ability to do it, practice it, et cetera, so we can prevent that response or that prompt. With Talia, we might get her to think this thing through, saying, wait a minute, I'm okay, I'm in school. These 14-year-old boys that sit next to me, they always say stupid things. He says stupid things to all the girls. It's not me, it's him. He's the problem. I'm just going to move my chair over here where I'm feeling a little bit more comfortable. That's going to take a lot to learn how to do just that. And we'll talk a little bit about that as we go along. With Robert, it would be something similar that we might be doing as far as intervention. This depicts a little bit of the brain that we're going to talk about how this reaction happens. We'll talk about 3 particular areas. One is called the amygdala, and the amygdala was built for survival. It's a flight or fight mechanism. It's built there for one thing, and it's to keep us alive. Another part of the brain is called the hippocampus, and the hippocampus really adds context. It begins to bring in some memory, et cetera. And the cerebral cortex, the thinking part of the brain, which also contains memories as well, but also is analytical and can take information from the amygdala and the hippocampus and translate it as to whether a person's in danger or not. So we'll talk about how they work in a normal person. Something stimulates us to cause a fearful response. A bang kind of thing like that, where you might be startled very quickly, and you jump very quickly, but you don't run after someone and attack them. That's because your hippocampus and your cerebral cortex are working just fine. Because the amygdala, the startle response happens immediately, and there's an immediate, right after that startle response, the brain starts saying, wait a minute, somebody just made a very loud noise in a classroom, you're okay, you're not in any trouble, this is all right. That all occurs in a fraction of a second. It's very rapid. That's the way the brain's designed to work. Well, what happens if we think about this from a standpoint of someone? And I remember the MRI I showed earlier. There were brain changes. We saw a shrinkage of the cerebral cortex, hippocampus. So there's some damage there. So this particular slide shows that damaged cerebral cortex, damaged hippocampus. The amygdala is working just fine, so the startle response is there. The follow-up response, which remember was pretty immediate, was right after the startle, isn't responding, isn't saying you're okay, isn't saying you're safe. So now, how does that startle response feel? It's very uncomfortable, and think about that being elongated for a longer period of time. What would you be thinking about other than my own particular safety? And a lot of times in particular safety, I might use aggression as a mechanism to keep myself safe in this particular situation. Scott Rauch did some studies with a psychotherapist who did some studies even further on people who experience trauma. And he did something quite special as he was having people recall or revisit their trauma. He was doing a PET scan of their brain while doing it. And he found something very significant. There are 4 slides up here, upper left, upper right, lower left, lower right. All but both uppers and lower left is where he was talking about trauma to the individual, all right? Only the bottom right is where he wasn't talking about their trauma. And there's a difference. In the upper right of each PET scan there, the upper right section, it's dark. If you look at the top, if the 3 where he's talking about trauma, it's only lit up in the lower right. See the place called Broca's area? That's the area of the brain that's responsible for speech and communication. And he surmised by this that while revisiting trauma, while a person's either being traumatized, recalling their trauma, being triggered by trauma, their ability to speak is going to be greatly limited. They're not going to be able to communicate. It's why so many times we see a person who's been triggered not be able to walk up to you and say, oh, by the way, I wanted to let you know that I've just been traumatized. We might want to employ some of those calming strategies that we talked about in my plan. It might be a good idea to do it now because I'll probably be displaying some of those warning signs in just a few seconds. I'm guessing they're not going to be able to do that because that brain section is not going to be able to communicate that kind of effect to that person. So we'll see it being communicated through behaviors. If we misinterpret those behaviors as aggression toward us, we're making it worse. We have to recognize saying, wait a minute, this person's telling me what's going on. I need to react in the proper way accordingly. Michael Pants Jack Panskep, I'm sorry. Jack Panskep did some studies with mice, and mice do 4 things, all right? They play, they eat, they poop, and they make more mice. That's what they do. Their whole life, that's all mice do. So he decided he would do a study, and they, mice brain are kind of the same, they function in similar ways that our brains do. All right, you like cheese, right? So, anyway, he decided that he would do an experiment with his mice that were born in the lab. And he grew these mice were born in the lab, had never been outside the lab, had never left their cages. And they played, and everything was just wonderful. So they'd never seen a cat in their life. So he took one cat hair and he put it inside the cage while they were playing. What do you think happened? Well, they immediately stopped playing. They immediately, as long as that, and you left that cat hair in there about 24 hours. And those mice are just shuddering away. So, what is that? It's a scary thing. Oh my, what? Do you know what it is? I'm not sure. If mice could talk, I think that's what they were probably saying to one another. Nevertheless, they weren't playing anymore. He says, that was pretty predictable because the pheromone from that cat hair is built into their instinctual, and they would probably react. He says, more importantly, when he took the cat hair out of it, the mice eventually returned to playing, but never to the degree and never to the extent that they played before. There was always some reservation. And so he surmised from this, saying, when a person, and those mice were obviously traumatized by this cat hair, he surmised that when a person who has been traumatized maybe one time would be a lifetime experience of looking over your shoulder, of thinking, when's it going to come again? And why we have that heightened sense of awareness, why people are constantly looking over the shoulder, kind of explains that from this perspective. I put some common reactions to trauma up here by Mary Gilbert. I'm not going through them all. You can read them. I like the way she splits them into the categories. Mary Gilbert's a psychotherapist up in Grand Rapids, Michigan. But she puts it in a very understandable fashion under physical reactions, mental reactions, emotional reactions, behavioral reactions. And especially in psychiatric settings, when we look at these kinds of things, we often take them for granted as being symptoms of a person having a psychiatric disorder. We often don't relate them to common symptoms or reactions to trauma. And so I think they'll be getting copies of this PowerPoint, so they'll be able to have it, so you'll be able to read and kind of look at them. Some other trauma-related symptoms, and you could read these. I'm not going to be going through or spending time with them. But I think that you can take a look and saying, a lot of times we see some of these as psychiatric symptoms, and we don't really relate them to trauma, and I really want to get people to be thinking more. Remember, the prevalence of trauma was so high, we can't ignore the fact that it's having a major effect on how the people behave and think. So what are we going to do about it? It sounds pretty dismal on how I presented what happens with an individual whose brain has now been changed as a result of trauma in their life. Do we just throw our hands up and say there's nothing we can do, or what is it? So there is something we can do. I want to say we don't have to throw our hands up. If we develop effective treatment, we have to think about they have a dysregulated system. So that the treatment has to look at that dysregulated system and work to help them to regulate. And also recognizing that there's a social environment that we often have in our behavioral health settings that doesn't contain this dysregulation. So we've got some work to do, is what I'm saying. It's not just a simple thing that we're going to be able to do with the prevalence of people. The goal of our treatment would be to help them maintain this calm, continuous, engaged state, which means we're going to prevent those discontinuous states, and we're going to build those cognitive structures. Remember that wedge of cognition I talked about earlier? We're going to teach them a neuroregulatory intervention of what they can do differently when they're triggered. Essentially, we're going to remove the cat hairs from the environment that we have. Thinking about it, I think about when we're going to discharge people from our behavioral health setting. Sometimes we're discharging them back to where there's lots of cat hairs. Sometimes we're even discharging them back to where the cat lives, all right? And I think we have to think about that. If we're talking about working with the individual who's triggered because of those cat hairs, those triggering events, those causative factors that happen, we're going to have to take into account and teach them the skills necessary to be able to deal with those things. It begins first with building a good treatment environment in our psychiatric settings. What does trauma-informed care look like? What do we expect people when we say you're going to be trauma-informed? How does it look? What would we do? It begins with how I began the presentation, was talking about recognizing that trauma is very prevalent in our society. And so many people are suffering from it, and they're not all hospitalized for sure. So if we recognize that this prevalence is there, and we take this universal precaution, so to speak, that everybody probably has a history of trauma, it begins there. We will always assess for trauma. We will always. Now, mind you, when we assess for trauma, what do we talk about? The Broca's area of the brain, when we ask the person to revisit their trauma, what's going to happen is, really? All right. What's going to happen with these individuals as a result of that, all right, is they may not be able to tell you what you want to hear, all right? They may not be able to give you the information. Focus on what happened to you versus what's wrong with you. Be informed by our current research. Keep learning more and more. Recognize that a coercive environment is re-traumatizing. Recognize that what we say, how we say it, what we look like when we say it, actually can make it worse. Trauma-informed care, it's got to be person-centered. It's got to be putting them in the driver's seat of what? Asking them things like, we're thinking about raising the doses of a medication. Do you think that might help? We're thinking about adding this to your programming. Do you think that would be beneficial for her? What do you think would help? We empower the recipient. We empower their family. Wellness and self-management are the gold. We want them to take charge of their own behavior. We want them to take that responsibility of moving forward and getting well. We need to be transparent in order to do that. Any effort of coercion, power, control has to be minimized. Staff, we train our staff. Not only do we train them, we can train people till the cows come home, but if we don't reinforce what we train, if we don't celebrate those successes, we don't provide corrective feedback, it's not going to happen. Focus on collaboration. We're going to engage. We're going to be in interactions that are kind, that are gentle, that are respectful, not that are demeaning, not disrespectful. We're not going to be coercive. We're going to respond to disruptive behaviors in a controlled manner, empathy, active listening skills. Sometimes we're not going to be able to do what they're asking. Sometimes we're going to have to take charge, but when we do so in a kind and empathetic and respectful manner. We have to be person-centered. I already talked a little bit about that. We have to be respectful. We have to be constantly conscious of our tone, noise level, body language. We have to be helpful. We have to be hopeful. When people come into our environment, are we welcoming? Do we look like we enjoy our job? Do we look like we want to help the individual? You know, I often tell people when you come on duty, you want to walk in and say, by the way, I want to let you know I'm going to be here for the next 8 hours. Anything I can do to help, please don't hesitate to come and ask me. That's what I'm here for. That's what I want to do. And I got a big smile on my face. Why wouldn't I do those kinds of things? I think it's important from our perspective to like our job and look like we like our job and actually instill that helpfulness and that hopefulness. We may be the only persons that's instilling hope in this person in their whole life. The language you use has to be chosen carefully. Our environment, as I talked about, being respectful, being welcoming. Look at our signage. Look at how we're talking with people. Look at how we're saying things to people. Look at how we actually do all of the things that we do in our day-to-day things. I often put this up so people can see it. I'm just going to let you read it. I see two major things that come out of this, and it says, just be kind and listen. Be kind and listen. If we could just do those two things, we're on our road to becoming trauma-informed. See, again, our job is to kind of clear that pathway. Our job is to help this person build, learn from it, gain some new skills, be able to taking their trauma history in mind and knowing we're going to do something with it, we're able to build them a more strengthened treatment model and teach those skills that they teach them the skills that they need to be successful in their lives. We do this, we get these persons thinking in that same way, learning, restoring their hope, knowing that we're understanding and recognizing that they can win. So the last thing I'll say is teach your staff about the pathways of trauma, teach your staff about the responsibilities of clearing those paths with sensitivity and understanding. Teach them about what traumatic stress is, what it means, and how we must help those with trauma learn new ways to cope with challenges so they can recover and lead a life with some meaning.
Thank you, David. As you talked about the science of trauma, I thought about that axiom that those of us who grew up in the helping professions kind of learned or heard growing up, which is to start where the client is at. So, in other words, be person-centered. Thank you. We are excited because we have an addition here to the panel I'd like to introduce so that we can continue our conversation about trauma. Dr. Jennifer Havens is an associate professor and vice chair for public psychiatry in the Department of Child and Adolescent Psychiatry at NYU Langone and director and chief of service of the Department of Child and Adolescent Psychiatry at Bellevue Hospital Center. She oversees New York City's most comprehensive continuum of mental health services for children and adolescents at Bellevue Hospital Center and the New York City Administration for Hospital Services. She also oversees a partnership with New York City ACS Division of Youth and Family Justice, integrating trauma-informed care into the 2 New York City juvenile detention centers. Dr. Havens, glad you're here.
I apologize for being late. It's not Manhattan, so I got lost.
Almost a little trauma there.
Yeah, yeah, I know.
We're glad you're here.
I'm sorry. And, yeah, thank you, David. Is this one of the ones you
Just
roll?
roll it.
Yes.
Yeah, you
Maybe
roll it.
you should
Okay,
roll it
I'll
for me.
roll it.
I'm not
Okay,
very
just let
good
me
at
know.
it. So I'm delighted to be here. I'm going to talk about a couple of different environments where we've tried to do exactly what David was talking about at the end of his talk, which is really make care trauma informed, and what are the kind of concrete and practical steps to actually do that. So that's, I'm going to be talking about Bellevue Hospital, where we started, and then we actually got a National Child Traumatic Stress Network grant 3 years ago to take the approach into New York City's 2 juvenile detention centers for kids. New York under 16, you commit a crime, you go into the ACS system, so it's there to secure facilities. So next, Dave. I have no conflicts of a financial nature to disclose, right? So you've heard about the ACEs study. I know we know traumatic exposure is extremely common in the general population. 47% of community youth report physical or sexual abuse or assault or witness violence. So it's the norm. And the bottom slide here I like to think of as you go up the acuity ladder, as you get into higher acuity settings, there's more and more PTSD. I actually think of it as a cofactor for admission to the hospital, because the kinds of things, at least with kids and adolescents, also with adults, but the kind of things with kids and adolescents that get you into the hospital: aggression, self-destructive behavior, suicidality, running away, early risk behaviors around sex and girls in particular, all things that are associated with traumatic exposure. And we know when we look at inpatient, this is acute inpatient populations, the rates of PTSD are between 20 and 30% in those populations. That doesn't mean like 80 to 90% of the kids are traumatized, but full syndrome PTSD is found in 20 to 30% of the kids. Thank you, David. So we have that as a reality. I think you've laid the groundwork for that very clearly. We also have a lot of challenges in recognizing traumatic exposure and its comorbidity with other mental health problems. A group in New Hampshire looked at kids in high-utilizing outpatient mental health settings, sort of the equivalent of New York State SED kids, and when they read their charts in the clinic, about 14% of the kids were diagnosed with PTSD. When they went out and researched the kids with structured interviews, and I'm going to talk about this in a bit, twice as many of the kids actually had met criteria for PTSD. The PTSD kids were functioning less well, and they were more delinquent and running away, and they were also on more meds, so the staff knew they were sicker, if you will, or struggling more, if you will. I know I'm cognizant of being next to Stephanie. But they didn't know exactly what they had half the time. And that's certainly, I see this all the time in inpatient settings. We spend a lot of our time at Bellevue taking kids between the age of 2 and 18 off of antipsychotics and off of mood stabilizers and treating them for depression and PTSD, which you don't treat with medications, and sometimes untreated ADHD instead of antipsychotics. We looked at 140 kids the first 140 kids we screened, I'll talk about our screening later, and compared kids who screened positive on the UCLA Reaction Index for PTSD, and they were more likely to be diagnosed with bipolar disorder, which they didn't have, by the way, when they were admitted. They were more likely to be on antipsychotics, so they were coming from the community on antipsychotics. They were on more medications, they were much more suicidal, and they had more prior hospitalizations. Next slide. So this, I think, there's a lot of confusion. I see this in the acute system. I see this when I consult in the state hospital. I think the inability for us really to make a diagnosis of traumatic exposure and trauma-related symptoms is really contributing to the massive overdiagnosis of bipolar disorder in our population. This is Sparks discharge data for New York City for primary diagnosis from a psychiatric ward, 0 to 19. You can see from 1990 to 2006, the rate of bipolar disorder just went through the roof, and the way bipolar disorder just stayed where it is, which is way too low. So I think it's this inability to really carefully tease out trauma and look at the diagnosis is actually contributing to the confusion we're struggling with, and it's not benign because we end up treating kids the wrong way. Next slide. So we see a very common pattern of kids with complex trauma backgrounds, and I don't think you talked about complex trauma, but there's PTSD, which is more or less associated with one event, like the World Trade Center falling down. And then there's complex trauma. Bessel van der Kolk, whose wonderful new book, The Body Keeps the Score, I recommend it highly. He's the person who's really been pushing this different diagnosis, developmental trauma disorder, where kids have lived in families all through their young life where they've been traumatized, and it's a much broader set of sequelae you see from this, but we see a lot of these kinds of kids, they come in with mood lability, either volatile aggression or self-destructive behavior, impulsivity. Everyone calls them emotionally dysregulated, and they're diagnosed as mood disorder, NOS. If you see mood disorder, NOS in a kid, in my opinion, it's PTSD till proven otherwise. Bipolar disorder, conduct disorder, and they're treated with antipsychotics and mood stabilizers. Next slide. And this is a concept, it's hard to see from where you are, but this is a conceptualization my colleague Molly Marr put together to try to help understand why there is so much confusion in making this diagnosis. When you look at depression is the green triangle, PTSD is the middle triangle, and ADHD is the right triangle. There's a huge amount of overlap in the way those symptoms present. They're different, but they present differently. I think people look at this confused mass and they say bipolar disorder, right? Seriously. And it's not accurate. At Bellevue, we use the regular DSM-4 criteria for bipolar disorder, which means you have to have durational symptoms, you have to have true mania, not irritability, true mania, so grandiosity, lack of lots of energy, lack of sleep. It's not kids whose moods are shifting all the time. It's not kids who are being triggered and who are explosive. Explosive behavior does not equal bipolar disorder. Next slide. And all these things are related. Early stress and trauma is connected to depression, produces depression. Depressed parents are more likely to stress and traumatize their kids. People who abuse and neglect their children or expose them to that do not do it from a position of strength. They usually themselves have been abused, and they're struggling with the adult sequelae. Early stress and trauma obviously causes PTSD, and we think there's a relationship between ADHD, early stress and trauma, and PTSD, because a lot of the very young children from the complex backgrounds that we see have very significant ADHD. Now, here's a caveat. If you have ADHD and depression and PTSD, and you're being treated with antipsychotics and mood stabilizers, other than the non-benign nature of those medications, there's another problem. If you actually have attention deficit hyperactivity disorder, what you need is more dopamine, That's what stimulants do. Antipsychotics block dopamine. Mood stabilizers, particularly Depakote, which is very commonly used in our chronically ill patients, actually makes you depressed. So we're giving kids the wrong meds, which is why we see these kids coming back to the hospital over and over and over again before we finally send them to the state hospitals, because they're not properly diagnosed and they're not being properly treated. And the only treatment for PTSD is psychotherapy. There is no drug treatment for PTSD. Medications could be helpful, like antidepressants if you're depressed. Prazosin can help you with nightmares, but there is no targeted drug for PTSD like there is for depression and psychosis and mania and ADHD. So what does it mean if you're a kid and you come into the hospital and nobody asks you about your trauma and no one understands you and someone gives you a pill? So, and this happens a lot in the hospitals, especially the hospitals that are under a lot of pressure to get kids out quick, because they're just more or less sedating kids. They're not really getting to the bottom of things. First of all, the major psychological sequelae of abuse is an internal sense of shame and guilt. And if you don't get that out of that kid, if you don't explain to that kid these things that happened to you shouldn't have happened to you, and they're bad things, and it's not your fault you react the way you react, you're actually colluding with shame and guilt and making it worse with kids. And I hear very commonly, we can't talk about trauma, we're going to re-traumatize the person, we can't ask about it, this is an acute care setting. I've seen some room for improvement in the state hospitals in how we work with kids around trauma. I absolutely disagree with the approach that you do not ask people about trauma, and that's why I like the reaction index, because it's a structured instrument that starts with impersonal traumas and moves to personal traumas. And we ask every kid that comes through our door the same set of questions. And if you ask that in a common, normal way, they will accept it and answer it. If they don't want to answer it, they don't have to answer it. Actually, the kids I worry about the most are the kids who score completely no on everything when I know them they're traumatized, because they're the kids that are really struggling with the numbness, repression, and avoidance, which are the most difficult things to work through in PTSD. So I said this already. I tell people, I yell at my staff, when you come to the hospital, what are you looking for? The right diagnosis and the right treatment plan. If we don't make the diagnosis, we can't make the treatment plan. I've already beat the dead horse. We're overutilizing antipsychotic medications. A third of atypical antipsychotics in the United States of America are prescribed to children, primarily minority children in the child welfare system. They are not psychotic, they're aggressive. And they're not aggressive because they're bipolar, they're aggressive because they're angry, and that's their survival mechanism. And they get triggered, and that's the only thing they know how to do to protect themselves. Next slide. So what do we do? You said, what do we do? All right, let's be specific about what is trauma-informed care. It's nice to have, like, be nice to your patients, be person-centered. That's lovely. What does that, practically, how do you make that happen in your environment? And that's what we did at Bellevue 8 years ago, and that's what we did in detention 3 years ago. And we think of three components to this. One is multidisciplinary staff education. And any staff education that does not focus specifically on the frontline staff isn't going to work. Because it isn't the doctors, sometimes it is. It's usually not the social workers, it's usually not the psychologists, but it's the people that are with the kids minute by minute by minute that need to know what they're dealing with, and that tend to get the least support and the least understanding. When I got to Bellevue 8 years ago, we call them psych techs, I think they're Mahatas in the state system, but my psych techs did not know the difference between a flashback and an oppositional kid. And if you don't know that, you're not going to be able to manage it. So multidisciplinary staff training, systematic screening. I would argue that every single psychiatric facility in the world, but certainly for children, should be screening for traumatic exposure and PTSD. I like to screen for depression, too, because that's under-recognized, particularly in aggressive boys, and problematic substance use, because the problematic substance use starts quite early in adolescence associated with PTSD, just like in adulthood. And then what are you going to do? Training. OMH is big on training. You sit in a room for 5 days and look at a bunch of PowerPoint slides, and you go back to your work. right? Doesn't work. I mean, we have a fabulous training in JJ that really works, but when we finished training everybody, they said, I need more skills. How do you keep it alive? And what we did at Bellevue was we developed skills groups that were focused on what traumatized and stressed kids need. So they work for everybody. And I'm going to talk about those more in a bit. And when you run those groups, you have multidisciplinary staff leading those groups, including nursing and psych techs, because then the training you've given people is reinforced by the milieu activities and the language that you're using with these kids. And it's a big secret, but I think it's actually more important to train and skill up the staff than to focus on the kids. We tend to focus on the kids, but we really need to focus on the staff. We're asking staff to work with very difficult children who are very unpredictable, who are very violent. Staff get hurt. Staff are traumatized. We often re-traumatize our staff by calling the Justice Center. So we really need to support our staff more appropriately than we do, and more thoroughly than we do, particularly the frontline staff. Go ahead. So here's our screening tools, just to give you some data. Any kid over 7 can be screened with the reaction index. There is no evidence-based screener under 7 for PTSD that doesn't require parental information, and most of the time with kids under 7 in our hospital, we don't have the parents because they're foster care kids, so we make clinical diagnoses. Again, I'll stress, 80% of my boys under 12 in my child unit are clinically depressed. And prepubertal depression is rare. It's not as rare as bipolar disorder, but it's rare. And Gabby Carlson at Downstate actually thinks all these kids who are being diagnosed as bipolar because they have a lot of mood lability and irritability are actually going to grow up to be depressed. And she's following that cohort out. Next slide. So this is hard to read, but a lot of traumatic exposure. The take-home message is rock solid for 7 years. 22 to 23% of the kids screen in the clinical range for PTSD on the reaction index, and another 10 to 12% sub-threshold, but significant clinical symptoms. So you're talking about 35% of your patient population. I think in the state hospitals it's probably more like 60, I would guess. And I don't believe we actually systematically use structured PTSD screening. The problem with making a diagnosis of PTSD, especially with a kid or a person who has had a lot of traumatic exposures, you have to go through all their trauma, you have to find the thing they think is the worst, and then you have to go through all the symptoms systematically of PTSD attached to those memories or those thoughts. It's not like check, 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 check. So it takes a little more time, but that's why nobody diagnoses it, I'm convinced. I was at Columbia for 18 years. I am not a big fan of structured instrumentation, except in this area, because I think otherwise we are really missing the boat a lot of the time. The other thing about screening is it normalizes the fact for the staff and for a kid that when you come into a therapeutic environment, we are going to ask you about these things. And kids don't want to talk about this stuff because it feels bad, and they, but we talk to them about it. We are not afraid to talk to them about it. If you can't talk about trauma with people, do not work in a mental health environment. Go get another job, because the worst thing you could do is flinch, because then you reinforce the internal stuff. Next slide. Depression, very, very common in little guys. Next slide. So let me tell you about our group interventions. Our length of stay is about 15 days, and I was trying to find something that we could do in 15 days that would give some foundational skills to kids around trauma and coping and developing better coping skills, as you discussed. Couldn't find anything. There's nothing for the acute world. So we went to Marilyn Cloitra, who is a colleague of mine at NYU. She's now out in California, and she had a CBT intervention for complex trauma called Skills Training and Affective Interpersonal Regulation. She tested it on adolescents and found it to be effective. So it's the regular CBT thing. There's a skills preparation phase, and then there's a narrative reprocessing part. We took the skills phase. We're not going to do narrative reprocessing in a group session, and we don't really have time to do narrative reprocessing in 15 days. You could do it in the state hospitals if you wanted to. And we took the skills in the group, the skills modules, and made them into groups. Affect recognition and trauma psychoeducation, emotional regulation and coping skills, with emphasis on an individual safety plan. So a kid will come in with a certain set of coping skills, like punching people and smoking weed, and we will try to figure out some more adaptive coping skills while they're in the hospital, and then we may give them a little card when they take it home so they have something in the community, and communication skills, like how to use this two-step, this is how I feel, this is what I want. A lot of these kids have no communication skills, as I'm sure the clinicians in the room and on the webinar are aware. Next slide. So that's what we did for the adolescents, 3 groups, manualized. You don't just go in there, it's not free form. We have the great glory of wonderful creative arts therapists, so our materials are actually fascinating. Kids like the groups, very helpful. We run 3 a week. You can go through it twice if you're there, skills-based. For the little kids, we did the same thing. We wanted something for the little guys who are really traumatized. We called up Judy Cohen, who developed trauma-focused CBT, and we said, Judy, how about a group intervention for kids in the hospital? And she said, you can't put those dysregulated kids all in the same room. I said, well, we sort of have to. So we took trauma-focused CBT, which is for children, and CBITS, which is a cognitive behavioral intervention for trauma in the schools, which is a group intervention for older kids, and we blended those two together, and we call it CARES, and we do psychoed, relaxation, coping skills, CBT, a lot of body work with the younger kids, and a little imaginal stress. The whole purpose of these groups is to cure your PTSD, is to help you understand what's happening inside you and have some more skills to calm yourself down when you get triggered. Because he said we got to teach them neuroregulatory, whatever that was. That's easier than it sounds. And we use, for psychoed, there's an amazing book called A Terrible Thing. It's about a red panda named Sherman. It's actually the best book about PTSD I've ever read. And the kids read it, and we give them the book to take home, and they love it. They usually never talked about their trauma. Like, they don't talk about their own trauma. It's like play therapy. It's displaced onto Sherman. But it's a wonderful tool for little kids. Next slide. So we did this at Bellevue, along with a couple other things, including getting to the respectful and the person-centered. We worked really hard to develop a positive behavior motivation system that was effective, where the staff reinforce kids every hour for not being a problem. They don't have to do anything right. They just have to not be a problem. And I like it because it forces the staff to communicate every hour in a positive way to the kids. A very limited emphasis on punishment and taking things away, really positive, and they get rewarded twice a day. So like if you've gotten your 42 points in the morning, you get to listen to your iPad at change of shift, iPod, which is very motivating for kids. You can put 15 kids in a room with one staff person, and it's immediate types of rewards. So we have a structured, positive environment that's very clear with very clear expectations. Most kids like snap to when they come into that. And we try very hard to ignore all negative behaviors unless they're really a safety issue. And that's a hard thing to achieve. I think we have work to do in those areas in our facilities. When I got to Bellevue, we basically had an infraction behavior management system. And that doesn't work because you just punish. Yep. So how much time do I have, timekeeper? Okay, so the commissioner of OMH of ACS in New York City, which is responsible for juvenile detention, asked me to come in and help in the 2 juvenile detention centers with the special support units, which were the voluntary units for kids who had mental health problems in the jails. And I said, I'm not really interested in that, but I would be really interested in trying to help your frontline staff work better with the kids. The jail population is obviously quite challenging. So we wrote a grant to the National Child Traumatic Stress Network, which is our wonderful $41 million a year program that's really had a huge impact getting trauma stuff out into the world. Their website, by the way, is fabulous for trauma resources of all kinds, and we were awarded this grant. Next slide. So trauma, it comes with just a juvenile justice involvement. In my opinion, the main drivers of going to jail are traumatic backgrounds, race, and really importantly, educational failure. The average reading level in these programs is like 3rd grade. So these are kids who've failed in school all along, and school is the thing that can rescue you from a difficult home and a difficult community, but they're not going to get rescued. So a lot of mental illness, a lot of ADHD, a lot of untreated ADHD. Next slide. A lot of maltreatment. The girls are unbelievable. The prevalence is 8 times in community samples in jail. Next slide. And we have the same struggles in the detention world that we have in the mental health world, where we weren't recognizing it. Most juvenile detention settings use the MAISY, which is a structured instrument. It's not bad for other things, but it does not diagnose PTSD at all. So same argument, you need to give people really clear tools to pick up PTSD, which include the screening. Next slide. So this is how we set up this project. Number 1, train the staff. Number 2, screen. Number 3, evidence-based skills so the staff can learn the skills and the kids can learn the skills at the same time. We have a broader goal, which I won't talk about. Keep going. And Monique Marrow, who is part of the National Child Traumatic Stress Network, developed this incredible training for frontline JJ staff called Think Trauma. It's the best adult education program I've ever seen. We should modify it for mental health populations and use it. It's not PowerPoint slides. It's a case-based thing where you get a piece of a puzzle and everybody figures it out together. We use a train-the-trainer model. When we train people from all disciplines, including the frontline staff in juvie. They're called JCs. They're trainers. And they go we train them, rehearse them, and then they go out and train their peers. Very powerful intervention to bring the frontline staff in as part of the learning experience. 4 modules. Why are delinquent kids traumatized? How some of your stuff, David? How does it affect development? How to see the way these kids act as survival coping skills. The only thing they know how to do, not as bad behavior, and really importantly, organizational stress and vicarious trauma in the staff. We triggered a lot of the staff with this training because a lot of these people have their own traumas, are traumatized at work. Fabulous training. Next slide. So then we looked at the screening. When we got there, less than 2% of the kids were diagnosed with PTSD. Less than 2%. Next slide. Keep going. So now we're more like 17%, depression 17%, problematic substance abuse 50% of the kids. A lot of the kids, I think, are using marijuana to calm themselves down. It doesn't treat PTSD, but it can be quite helpful for some kids. I'm not recommending it, obviously, but I think that's one of the drivers of the heavy marijuana use. Next slide. Then we sucked the juvenile counselors in with this Think Trauma training. They liked it so much, we offered to train them to co-run these groups with us. Now, these are not counselors. They're called counselors. They're child care staff. That's what ACS uses. And they're minute by minute, 8 to 1 on the halls with these kids. They need skills. They need help. And they said at the end of the Think Trauma training, this is great, but we need more skills. So we trained them to run STAIR groups with us, along with a mental health person. And we have 131 people trained. We've completed a whole bunch of groups. About 80% of the kids that come through the facilities get these foundational skills. Next slide. It's had a big effect on the milieu, I think, because the staff now understand. They told me when we were trying to set up this project, they said, we don't understand these kids are too crazy for us. And very few of these kids are psychotic, very few of them are actually bipolar, but they're quite volatile and difficult and quite easy to trigger. And they do things in jail like they lock them in the room. For some kids, being locked in their room at night is a trigger because bad things happened in their room. So changing the way they understand the kids, and we actually work with them on an individualized safety plan. With a kid, we develop a plan. This is what triggers me. These are what my alternatives are in this setting. We don't talk to the JCs about the kids' specific traumas, but we work with them so they actually, on an individual kid-by-kid basis, learn to use these skills and understand that. And that, along with that and running the STAIR groups, has really changed the way a lot of them think about the kids. So that, I would argue, is a practical approach to making a place trauma-informed. Identify it. Don't leave it up to your clinicians. Identify it. Get your frontline staff in there from the beginning in terms of training and make them your champions. And you will change your environment for these kids, and we'll be much more effective in putting these kids back together and putting them on the road to doing the longer-term work they really need to do to recover from the awful things that happen to many of our patients. Thank you.
Dr. Havens, thank you for sharing your important work. I think it's very thought-provoking, and I want to move our discussion forward. I think we have a nice progression here. We're now going to hear from Stephanie Orlando and Monica Jeffries to give us the lived experience perspective. Stephanie?
All right. Are you going to do the thing, David, or do you want me to?
You want to do?
She probably
Sorry,
has.
a little
She
housekeeping
probably has
first.
manual skills I don't
yeah.
have, right?
Just make sure I got the right direction down first. Okay, so I'm Stephanie Orlando, and I'm the Executive Director of Youth Power. And I'm just going to kick us off by just telling you a little bit about Youth Power in case you aren't aware of who we are. We've been working with the Office of Mental Health over the past few years on restraint and seclusion reduction efforts. It's been part of our priority agenda for many years since we first started having an advocacy agenda statewide. And Youth Power is the New York State network of young people who have been labeled and are seeking change. And we mean that labeled in any state system primarily. Together we have decided to speak up about our experiences because no one knows what it is like for us better than we do. Through peer-to-peer mentoring, we empower young people to be active citizens who are aware of government operations, their rights, and the ability to use their voices to influence policy, practice, regulation, and law. We are young people helping other people, ensuring the availability of self-help and peer support while changing systems so that young people get the support they need with the respect and dignity they deserve. We're entirely youth-run, and again, we are cross systems, and that's the perspective that we're going to be bringing today, is really that it's really hard for us, and why we became cross systems was because we always were. It was really hard for us to find one member that really only touched one specialized child serving system. So whether we were in special ed and mental health or juvenile justice and placed in an RTC and all of these things, DeMonica and I have cross systems experience, and that's the perspective that we'll be coming from. And I think it's really great that while we're talking about trauma, we are talking about trauma and juvenile justice, and knowing that really statistically nationally you have a huge overrepresentation of youth with learning disabilities and traumatic experience in foster care and in juvenile justice. And so and there's been a huge rise of just seeing trauma and even trauma-informed schools in areas like Oakland, California, where trauma is at a high rate in the community to have trauma-informed schools. So just really echoing what's been said so far and making sure that everyone that's listening understands that trauma is prevalent in young people and it applies to all systems of care. So with that, I'm going to turn it over to DeMonica to talk about her experience. DeMonica?
Hi, my name is DeMonica Jeffries. I graduated from the College of St. Rose in 2012 with my bachelor's in sociology, and I got a minor in public health. During my time at St. Rose, I interned through the Office of Children and Family Services at the Professional Development Program in their Child Welfare Department. I interned there for 2 years, and then after that I moved on to be a youth ambassador, where I ran workshops for young people in foster care, helping them understand their opportunities in higher education. From there, I ran a teen parent mentoring program in Schenectady for about a year, and now I'm here at Youth Power. I'm very excited to be the Hudson River Regional Youth Partner, and I'm very grateful that I'm able to use my experience in the foster care and mental health systems to be able to help inform people of the importance of eliminating restraint and seclusion. So, like I said, I have both lived experience in foster care and mental health. I was in the foster care system from about the age of 3 up until my 21st birthday. I graduated, or I was in college when I aged out of the foster care system. While I was in the foster care system, I was diagnosed with 3 different mental health issues, and I was placed on medication for all 3 of them until I was about 18 when I decided that I no longer needed them. I haven't been on medication for any of them since. So I'm not quite sure which ones I actually have, which ones I don't, but I seem to be doing pretty well with all 3 of them, or none of them at this point. So the first time I remember being restrained, I was probably about 6 years old. I was in a foster home that I wasn't very happy with. I was removed from my mom, like I said, around age 3, and I was still having visitation with her at the time. During the visitation times, me and my sisters would have an amazing time, and then we would all get separated back to our different foster homes and without our mother. So whenever I would get back to my foster home, most times I would start out by just crying in my room alone, and then I would start screaming, and then I'd start throwing stuff. And after that, I'd get restrained for doing that. I wasn't necessarily going or trying to hurt anyone else, but I wasn't really sure at that time how to manage, the stress and the anger and the sadness that I was dealing with. So from about 7 to 13, I was in the same foster home. It was a therapeutic foster home, and I think most of my issues there came from lack of training to my foster parents on what types of trauma I was dealing with and the issues that came along with having a child who was taken from her foster parents. They adopted me when I was 12, and that was a really difficult time because my sisters weren't adopted with me, and I was still not quite over the fact that I was never going to be with my parents. They loved me, and I knew that they loved me, but it was still difficult for me to accept that this was my family when I still had another family. So I acted out a lot in that foster home. So at 13 was one of the last times that I acted out. During the times that I was at my height, I was probably getting restrained about 2 or 3 times a month. The last time that I acted out, I had actually fought back from my restraint. And the cops were called. I was 13 years old. The cops were called. I was taken away from my foster home in handcuffs. And I was sent to a residential facility where my adopted parents at that time decided that they no longer wanted to be my adopted parents. And so I stayed in the residential until I was 18, which then I went back into the foster care system. So this just continued, obviously, to re-traumatize me. Not only was I already dealing with the fact that I had lost most of my family, but also now I had lost my adopted family, who were supposed to be the ones who were going to take me and love me forever. So yes, that was obviously a really difficult time. Had I have gotten or been taught the skills to communicate effectively with the adults in my life who were trying to help me, or had I had gotten the skills to maybe breathe correctly during these times, I think that would have been extremely helpful in keeping me from thinking that screaming or throwing things at walls was going to be the way to deal with my anger, frustration, and sadness. A lot of times I remember being held down and being told to breathe, which was one of the most frustrating things ever, because when you're held down on the ground, being told to breathe, I just wanted to scream. I'm breathing, obviously, I'm screaming, right? So I have to be breathing. But I didn't know how to effectively breathe. I didn't know that that there was a technique to it. And being told when you're at the height of your aggression is definitely not the right time to be telling someone, how to calm down. So I think had I have gotten those skills when I was younger, it would probably be really beneficial. It would have been really beneficial, and maybe not have resulted in me being removed from my foster home. Today, I feel extremely bad for my foster parents. We don't have or my adopted parents. We don't have contact anymore, and I can only imagine even for them how hurt they must have been to have lost, a daughter because of some of the issues that I had. Had they have been trained, though, that probably could have been all eliminated, and we could have all had a more successful family unit, or at least we could have reconciled and learned to deal with what issues we had. But they weren't willing to deal with that because they didn't know how to. So I also feel bad for them as well, because that's not something that any I don't think most foster parents go into it, and especially not adoptive parents, go into it thinking that they're going to, one day have to give up the child who they're choosing to take in. So I think that as long as foster parents, adoptive parents, any caregiver, out-of-home placements are better trained, informed on the issues that come with having a child who's been traumatized, who's being taken away from their normal, is extremely important. And I know not only I, but many other young people in out-of-home placements really seek normalcy. That's one of the things that we want most. So being in a home or a residential facility where you're being restrained doesn't really present that atmosphere of normalcy. So I think that as long as we're talking about this issue, and normalcy is a huge part of it, I really believe that taking out restraint and seclusion in the lives of young people who've already been traumatized enough would be extremely beneficial.
Thank you. All right, and I still don't have the direction down.
It's hard.
So, well, thank you, DeMonica, for sharing your experience. And I'll just quickly touch on a little bit of mine, and then what my plan for the rest of the portion of our Youth Power time is to just talk a little bit about consumer involvement and how important it is. It is one of the 6 core strategies for reducing and eliminating restraint and seclusion by NASHBIT, and so that I'll be doing a portion of their training as well as some of our own pieces. And like I said, we've been going around doing some of this with OMH in the past, and so it's nice to bring it to more of you. Personally, I had experienced trauma and through both witnessing abuse and also personally experiencing abuse as a child. And I really didn't start to enter the mental health system and really exhibit like a serious issues until I was starting to reach puberty and adolescence. And at the time that, I was probably 11, 12 years old, people would ask me a lot about if I was experiencing trauma at the time, and I wasn't at that point. My mother had gotten us into a different environment, and we just that wasn't happening at the time. And so I just kept saying, like, no, that's not a part of what's happening to me right now. And as a youth, I really didn't understand the long-term effects of trauma, and through both some of my counseling experiences, but also just being in the peer movement for as long, I've really come to understand how much trauma has impacted my mental health and really caused a lot of the issues that landed me in the mental health system and other systems of care. Particularly, I was diagnosed with anxiety, severe depression, and agoraphobia. I was afraid to leave my house for many years, and now I'm a public speaker and travel. I know you guys are laughing. People are like, "What? You can't believe that, right?" But really, it was all panic associated with trauma and really that fight or flight kind of mechanism. And I still get that very often whenever I feel trapped or someone's standing over me or I'm cornered. And I didn't really learn any of the self-regulation techniques that I know now in the upper level settings of mental health or in residential facilities. I actually learned it in an adult anxiety and phobia group where I was with people 30 to 50 years older than me, literally, where I was the only young person in the group, and my counselor had really fought to get me in there, and that's where I learned all the self-help and self-regulation tools I use today. And breathing, DeMonica and I were talking about this before when we were preparing, and I used to be one of those strong-willed children that would throw temper tantrums and stuff too, and my sister used to pin me down and sit on me and go, "Count to 10 and breathe." And that honestly was like kind of triggering to remember that, and then to relate that once I really did learn how to breathe, that is one of my most regular go-to meditation, self-relaxation, just knowing that oxygen is good for your mental state. Those kind of things I really learned through those self-help groups and learning those techniques. And so it's really encouraging to hear more that that's what the direction that we're moving in, is to really teach people the tools that they need to help themselves long term. When I was in a residential facility, my motivator to go to school was that if I didn't go, I was refusing and I would most likely be restrained. And having had that experience of physical abuse as a child and witnessing it and being in an environment, it very much made me feel like that again. Like I was still in an environment where I was not safe, that I could not, where my motivation was physical and not, internal of my own. And so just really understanding that it really does affect everyone there, the staff that have to experience restraint, the youth that are witnessing the restraint, and most importantly, the young person or the person going through restraint. And I know that we're speaking mostly from a youth perspective today, but I do want to also say that a lot of what we're talking about is very true for adults. And especially the consumer involvement piece that I'm about to speak to next is completely relevant and actually more from the adult world in its roots. So that's what I'm going to talk a little bit about actually next. In the mental health world, the peer recovery movement has created many changes in the mental health world, starting in the 1970s, where you really saw the radical liberation movement of people saying that they're survivors of psychiatry, and really, you laugh, but that's a real thing. People were. I mean, when you have people that were forced DCT and don't remember their wedding and all sorts of things, that's the radical liberation movement. And you saw a lot of the liberation, Mental Patients Liberation Alliance and other groups in New York and nationally. In the 80s, more real recognition of the movement started to happen, where you would get funding for these efforts. And in the 1990s, really starting to see it being peer specialists really being introduced as in the mainstream, including then, like I started my peer advocacy career in the youth movement in the 1990s. So, it really was even reaching the youth world then, where SAMHSA was starting to do a lot of their youth-guided work in the late 90s, early 2000s. And, we are still catching up in the youth movement to the adult movement and the family peer support movement. But, we're right up there really showing the value that peers can have in both changing the environment, the way that services are delivered, but also instilling hope and skills within our peers. So involving those you serve, what does that look like? What would that mean? First and foremost, we want to integrate choice at every opportunity and really have people have a voice in their own services and the treatment that they're receiving, as well as, what their goals are. Often, especially in the children's world, we give these cookie-cutter approaches and, we put people on behavioral plans where everyone in the facility will have very, very similar goals, suspiciously. And we all have our own stories, and really making sure that we are at the center of the choices regardless of age. And that one of the things that, although we haven't ratified the UN Convention on the Rights of Persons with Disabilities, one of the things that it says in there is that young people will be included in a way that's developmentally appropriate at every stage. And so really making sure that we have opportunity for choice and voice throughout our lifespan. We also promote cultural change through inclusion within recipient services. So how are services being delivered? What's the policy behind it? How do we redesign the space that we're in? Maybe we need to design a comfort room. What would that look like? What sensory tools should we have? What art groups should we do, or activities should we have? Even to say that within the PARS project, we had people involved in debriefing sessions. We had people looking at data and saying, like, what does this data mean for us? Like, if we're coming back from school and we have a high rate of restraint at that point, what from our perspective would help change that? Maybe it is, as Clarence Sundrum said in the first webinar of this series, maybe it is something as simple as cookies and milk at bedtime. I thought that was a great piece. And a lot of times the youth themselves can tell you what those things are, especially because generationally we have different cultural views. Like, this is a very technology-based generation and very multi-stimuli generation. There's different things that they might find useful, like you were talking about an iPod, like do you know how hard it is for youth to get their hands on an iPod in a facility sometimes, most of the time? Like they'll come up with all sorts of excuses why they can't, and I just keep saying, how about some wireless headphones? Like really, seriously, if you're that worried about the wire, just, well, there's wireless technology, you know, like let's move forward here and get your safety people on board, you know. So really having that perspective of the person involved in all aspects of designing the services that you deliver and maintaining quality. The SAMHSA and Youth Move National have developed this definition of what youth guided means, and really youth guided is the sense of really having worthwhile input and sustainable voice, and someone actually listening to that voice within the services, and within systems of care. So when I'm saying systems of care, I'm talking about any child serving system or service. They're really making sure that they have that voice, and that it's not just a thing that comes and goes and is, you know, tokenized and, you know, saying, oh, we got that youth there, they're there, but really having the power to make change, to be seen as a partner and as a valuable stakeholder. I mentioned that I was in a residential treatment facility or treatment center, and when about a year or two after I was out, the commissioner of the county introduced me to the new director of the facility, and I was able to go back and be on their strategic planning committee for the next few years. And it was very meaningful for me personally, but also to inform the agency what direction would best serve youth from a youth perspective. And you know, really the forward thinkers in the group weren't, you know, far off from what I wanted to see happen within the facility. So really understanding that perspective and making sure that youth are seen as partners in that process. So within the continuum of youth guided, you have, this is a what's called Hart's Ladder, and it's often used within the youth guided youth movement. So at the bottom you have decoration, manipulation, and tokenism. And that's where you see youth as clients that are there to be served, that their perspective is, you know, just minimal, like to be seen as a valuable thing. Like it's nice to say that they're there at the meeting, but there's no real meaningful follow through with any of the direction that they've suggested, or any of real true listening and follow through with what they've said. When you get to the middle rungs, you have more of that kind of idea that while I'm involving them, it's helpful for them. It's not necessarily helpful for me as the provider. Mm-hmm. They're going to get something out of having this leadership experience. I'm going to teach them something. Whereas when you get to the top, you learn that both perspectives, the youth are learning from that experience, but you're learning from hearing their perspective of the world, hearing their perspective of the services that they've received, of the environment when they're entering, of all of those different aspects, and that they have a valuable perspective to provide you as an expert within receiving those services and of navigating the system as it stands today. Some ways to encourage youth involvement is to have youth input on the treatment plan, obviously, their accounting plan, sensory tools, all of those kind of things, as we talked about earlier. Membership in decision-making bodies and steering committees, on hire and evaluation of staff, which I think this is another example that I want to pull from the PARS project, because I like to always talk about House of Good Shepherd, and how in one of our webinars they talked about how they had a young man on the hiring team, and they were all set to hire this one person, and they asked the youth, you know, what did he think? And he said, well, every time I asked a question, the person never looked at me. They always looked to someone else, and if this person's here to help me, I want them to look at me and answer the question. And so they didn't hire that person. They hired someone that was able to speak to the young person and recognize that they asked them the question, which is just a great example from an RTF. And so think about how you can include people, not necessarily just youth, but also adults, in the hiring practices of staff. And then for student councils and let's just say councils in general, they can be student or participant run. Sometimes they call them community meetings too that are run by the people that are in the facilities, where they can really have a say in like what comes up next. So like, let's say they have an opportunity to do an activity or to plan something, or even their menu or whatever the situation is, that they're as a group able to come up with those decisions and see themselves as leaders and as contributors and having a valuable voice. And remembering that, like, coming from a traumatic history, like, a lot of us don't see ourselves as being valuable. And so to be put in a position where, we're told we are capable and a leader and that our voice matters really does impact our overall mental health and well-being. A lot of us talk about like shadow beliefs and negative thoughts that we have based on the abuse that we've experienced. And so having those positive, encouraging things that focus on our strengths is incredibly helpful. And again, it's not only helpful for us, but it's helpful for the service that as well in providing quality service. So peers can serve as role models, communicators, mediators, teachers, and legal protectors. So meaning that not only can they be provide peer support, but also be an advocate, really help make sure that people understand their rights. From the liberation days, you have people even posting signs of what lithium toxicity looked like so that they could monitor that within their peers. And, I was telling some young people about that the other day, or a couple months ago, and they were like, they should still do that.
They should. We should.
But also, too, like there was mention in the Justice Center, but one of our big issues is that how do we even get access to the phone to call the Justice Center? So really understanding what our rights are if we experience or witness abuse of our peers in facilities and being able to talk about that. Being able to provide support from an experiential level rather than just from a level of professional authority. Being able to say, like, I've been there, or I've been somewhere similar, and I've learned how to navigate this. I'll go through this with you. You're not alone. A lot of us feel alone, and there's a lot of stigma out there around these mental health, and so to be able to feel comfortable and not judged from someone that is your equal is incredibly important. And we provide those firsthand experiences and unique insights that are really needed to understand what people are going through. So this is another oldie but goodie. Concepts of self-help and peer support. Our problems are due to real causes. We are people, not diagnoses. Our needs are basically the same as those of everyone else. We validate people. We believe in ourselves and in others. We trust in our feelings. We nurture a positive self-image. We all need hope. We are responsible for our own actions. This is, again, the roots of the self-help and peer support movement, and they still hold true today. The underlying values of self-help, obviously it's empowerment. We want to make sure people know that they have the skills that they can to recover, and that recovery is real. We also want to model independence, and that, even with support, independence is possible, and that we can live in the community and be fully integrated into the community and have those opportunities and choices in our lives. We have responsibility for our actions, as we talked about before. Too often, like, people, say, especially to young people, it's challenging when you're like, well, that's because of your diagnosis. It takes the power and away from the person, and just to teach, maybe that trauma is the reason for that issue, but you still have control of what happens next. And we have actually heard that from one of our New York City members that was saying, her first response to trauma was that she didn't really like being told that the reason for all of her actions was that trauma. Like, that was kind of difficult for her, but understanding that you're not limited by that experience, and that you're not just that ACE study, you're not just based on your ACE study score, but that you have the ability to set your own path and to learn the things to manage your own wellness and self-help. We talk about dignity and even the dignity of failure and having choice and trying things and seeing if they work. A lot of times we try and protect people from failure, and especially for adolescents, how do you know if you like something if you don't try it? It doesn't necessarily mean that You failed because you tried something and then decided it wasn't for you. And so to have those kind of experiences and to frame things in that way is important. And then we have social action where we really we do demonstrations and all of those types of things. We've definitely led a chant or two of hey, hey, ho, ho, restraint and seclusions, got to go. So, just really trying to make sure that young people and people in general who receive services have a say in those, understanding that you'll have a better view of what they're experiencing so that you can improve the services that you're offering to them. And so that restraint does go down because people feel heard, they feel valued, they feel understood, and that they have the tools at their disposal that they need to self-regulate and to self-soothe and to calm themselves. So thank you.
Thank you, Stephanie. Thank you, DeMonica. Stephanie, as you were talking, you mentioned two examples, the headphones issue and the access to phones, where perhaps rules were kind of rigidly followed for one reason or another, and there may be value in that. But I wonder if the two of you could talk a little bit about, when rules are followed rigidly or the importance of flexibility with rules.
Okay. Yeah, so obviously if you're going to really stick to a rule that is just old hat, like I think one of the things that we always use is like our little anecdote is the lady with the roast. You guys know this one, where it's like this woman, she always cut off the end of the roast, lamb roast, and I'm a vegetarian, so sorry, but she would cut off the end of the roast, and her daughter asked her, "Mom, why do you always do that? Why do you cut the end of the roast off?" And she's like, "I don't know, my grandmother always did it." And so then they asked the grandmother, and she said, "Well, I did it because my pan was too small." So it's like we pass down these ideas and these things that aren't even rules that need to be enforced, and sometimes they have no logic or reason behind them. So I think that following the rules in a rigid sense, it often creates that power dynamic and that coercion and control that isn't always necessary. And I think really around calming and comfort tools, I think when you're like, certain things should be not seen as a privilege. They should just be part of your self-soothing and comfort plans and your crisis plan, whatever plan you want to call it. But if somebody says, "Hey, what I need to calm down is to listen to my music," that shouldn't be a privilege. That should just be something that occurs because that's what they'll do when they go home too. And I think that people need to understand that certain things that are seen as privileges in a facility are really natural supports and things that we'll do naturally to soothe ourselves when we get home. And don't you want to teach those things that we can use for the rest of our lives? Because I think you do. So let's focus on that.
And that's how the comfort rooms, the really good comfort rooms, which are sort of out of most of our price ranges, but we're working towards them at Bellevue, that's how they work. The kid who is upset goes into the comfort room, and it's not a reward, it's a tool, and they control the sensory equipment completely. They control which sensory equipment they use and how much light there is and how much noise there is, and it's really using a kid's own internal power to bring them down. It's hard to do in the kind of environments we work in, but it's really helpful.
We found that during the PARS grant, we would get facilities to think about rules and to revisit rules, because the blind enforcement of rules was found to be a huge causative factor to produce a situation which would end up in restraint or seclusion. So we really got them to take a look at rules and maybe divide them into 2 types or 3 types, red and green rules, or red, yellow, and green rules. And basically the red rules are those that had to be upheld. They were safety rules. They were issues that really, but green rules, staff had the right to not follow, could bend, could break. If it was going to avoid a restraint, if it was going to avoid a crisis, the staff were empowered to make those decisions, saying it wasn't important to enforce the rule at that point. It was more important to meet the needs of the individual.
We talked a little bit, or the folks talked a little bit about comfort rooms and sensory tools, and I'm not sure, I know certainly in OMH we know what those terms mean, but I wonder if some of the panelists can give examples of what a comfort room is, what a sensory tool is.
Well, a comfort room basically is a room that really sets itself up as being comfort. So we like to use the word comfort and sensory as somewhat synonymous, because I think it can have a multi-use. Some agencies might want separate rooms for it, but I think one room can suffice for it. But when we think about using it for a sense of comfort, I talked about neuroregulatory interventions, and they're basically cognitive restructuring skills that we want to teach anyone to do, whether it's counting to 10, whether it's visualization, whether it's taking some deep breathing, mindfulness exercises, or whatever we can get that person that works for them. We found that using sensory modulation as a tool to augment that ability to cognitively restructure was something that was very, very helpful. So in considering a comfort room, having a room set aside that had a variety of sensory equipment, which means we have to really address all 7 senses. And when I say 7, we know the 5, but we add those 2 others of proprioception and vestibular input, where rocking and swinging on a swing or glider, et cetera, adds that vestibular input, that sense of motion. And also proprioception, which is the use of our extremities and the knowledge of the communication our extremity muscles and tendons, et cetera, have directly to our brain. So with every individual, a sensory diet can be established to find out what sensory item is soothing for them, what sensory item is alerting to them, whether it's squeezing a squeeze ball, listening to music, watching a lava lamp go, shooting hoops on it, riding a bicycle, just looking at those things. So when we create a comfort room, we create a room that has a variety of sensory equipment that the person now can choose. Here's what I want to do. And I often say, I know what I would want. I would walk in the room and I would want to sit down in this really comfortable chair, and I want to put the ocean crashing waves on the TV screen, and I would want the smell of the ocean there, and I would put a little violin music on, playing a canon in D or something like that, and I want the lights a little bit low, and then maybe I'll be able to rock in that chair that I'm sitting in so comfortably. And that would be extremely relaxing, and I could take myself someplace else. For everybody else, it's something different. It's highly individualized. So when we develop comfort rooms, is what I'm saying, people, and Doctor, you're absolutely right. If you want to use the most expensive, I don't want to use the name, but you can use the most expensive equipment out there, and it will cost you huge amounts of money. But
I like the bubble ones.
Oh yes.
They have these like hot tubs that are full of clear plastic bubbles, and you get in them, and you can control the sound. The sound comes through them, and the lights flash on them. So, I mean, that's. I'd much rather say to a kid, go get in the bath right there, than go in the seclusion room. That's a much better.
So the idea is be able to, and I'm glad you said, because you said something that's most important when we talk about using comfort rooms. It's not a reward for good behavior, all right? It's not a punishment. It's a tool. It's a strategy. And I think one of the most difficult thing we have is staff recognizing that I may have to start using it after the fact, after someone has lost control, in order to regain control. Because I'm really trying to teach them that you could choose to use this before you lost that control, and it's using it from that perspective. So hopefully I've answered.
I had a patient who at another, not my facility, but another facility, they had comfort rooms where they had to sign up an hour in advance.
No,
That's not right.
I just want to also mention that we have some good resources on the Restraint and Seclusion website that I don't know the address to offhand, but there's a guidebook on like how to create a comfort room and all.
It's on the OMH page of the internet where everybody can get to. If you went to the OMH internet and typed in and went to Positive Alternatives to Restraint and Seclusion, the page will come up, and there's a whole comfort room guide that's right on the internet.
I thought we created a new multi.
We'll get the
page,
link. We're
but-
going to get the link
Yeah.
out to the audience on the webcast and through the distribution means that we used to get the announcement for today. The other piece I want to mention is if an organization doesn't have the physical space for a dedicated comfort room, there are other options, are there not?
Yeah, there's things like comfort carts, which people have refurbished, like old med carts into comfort carts where people have different things. People have made backpacks for youth that had their sensory tools and their comfort tools in them. Just anything. It's more about the access to the tools and having a safe place to use them, where and maybe even a setting where it's appropriate to you, depending on what the tool is, especially if it'll impact other people. But, again, a lot of this stuff is very portable. Like, one of our board members uses one of these, like, portable sensory, like, smell things that she just holds it up to her nose and smells it whenever she needs to. And you just think, like, when you learn the things that trigger you and then the things that calm you, if you feel triggered, it's as simple as pulling out that fragrance that helps calm you down. And that's something she carries with her in the community and at school and work. And so those are tools, too, that we could use, and it's not just about the room.
Great. I want to be sure we get to some of your questions, so I'm going to hand it over to Laura, who has a question from the email address. Go ahead, Laura.
Yes, I do, but before I get to that, I just wanted to add one thing, because sensory tools, I just want to encourage everybody to get creative, be innovative, go online, see what's out there. Last year I found an amazing non-toxic silicone putty, which is amazing to look at and to touch and to mush. And we've been talking about Fireball PRN for years, and maybe David can just take a moment and talk about that before I move on to the email. Because we know about the use of nice hot candy, if people like that, or warheads, and what that can do for folks. But if you're worried about choking, and that's where the safety people come in again, when you're worried about that, you can also buy spray candy. There's spray sour candy, there's spray hot candy. So if David could just take a moment, and then we'll do this email.
Well, I think she's referring to my example of years ago. We had a person who suffered horribly from a lot of delusional thinking and hallucinations, and for years and years, therapeutic smoke seemed to work for him. The man was tormented by hallucinations. They were either silly ones, happy ones, or horrifying ones, and literally he lived a life of hallucinations. But we found that by offering him a therapeutic smoke, which we did quite frequently during the day, it wouldn't stop the hallucination, but it would switch it from the mechanical men jumping out of the ceiling to something telling a silly joke, and he'd be starting to laugh. So we would just take liberty and give this man a smoke as often as we possibly could. Well, smoking disappeared from our facilities, as we all know. And what are we going to do with Stubbs? I mean, how are we going to make this thing work? And we fell upon this we found that Fireballs did exactly the same thing for him. Okay. When he popped it in his mouth, the hot cinnamon didn't stop the hallucination, but it changed it over, and he was no longer having to fight and be restrained. So all the staff carried Fireballs in their pockets.
And you didn't have to deal with Bloomberg, right? Candy's bad.
We didn't have to deal with it.
We'll save that for the next webcast. So here we have a great email from an OPWDD provider. This is from George Seuss, the CEO of the ARC of Delaware County, and he says, hello. Eliminating the use of physical intervention requires a few key elements. One is staff training and development. Another is monitoring performance, as is proper data collection, and there are others. But the one that does not receive nearly enough attention is the role of volunteer and paid leadership. So the question is, does the panel see the element of leadership as crucial to reducing and eliminating physical intervention? And if so, what strategies do they see emerging to address the board of directors and executive staff role and responsibility in regard to eliminating physical intervention? Thank you.
If you look at the 6 core strategies for reducing the use of seclusion and restraint, the first core strategy is leadership. And without leadership involvement, without leadership buy-in, without leadership leading the way and making it happen, blazing the trail, and agreeing that this is going to take a lot of effort, this is going to take a lot of, and I have to be involved. In leadership, it also talks about a thing called witnessing, where it talks about cabinet-level people being involved when a crisis occurs, getting on there to be supportive, both to the person we're serving and people doing the services as well, to show that, we take crisis really seriously. We take the need. So he's absolutely correct. If leadership is not on board, it's not sold into it. And when I say leadership, I talk about leadership from the top and filter it all the way down. Everybody has to have this, be on the same page. Everybody has to be willing to do it because it will cost some extra money. It will take extra time. It's going to be, we're not going to be perfect, right? I'm sure you found that to be, Doctor. It doesn't work for a while. You have to work it into the system.
And you can never stop watching it, right?
That's right. That's right. So,
But it has to come from both directions. I think obviously leadership is key, but it also has to come from the bottom up. And I think we forget that a lot, that really, if you want to change culture in a residential setting, everybody, including the people who historically have the least power, other than the kids, but the kids have a lot of power in other ways, but it's the frontline staff. And if I had to choose, I'd rather put all of my energy with the frontline staff than with the clinical staff, because they're the ones who really have to understand, and they're the ones who have to tell us what they need, to be effective with the kids.
I think too that they help teach each other and support each other, and for as much as someone that really stands for peer support, I think that peer support is needed staff to staff too. And one of the other great examples from our work is one of the organizations that they use trauma-informed care is like an acronym, and they would use this code to go up and say to people, like, if they needed to kind of get tapped out and they were overstepping a situation, they would have another staff would go up to them and be like, I think you need a Tic Tac.
Yep.
And then if they did something really good, someone will go up and say, wow, you did really good, here's a Tic Tac. And just that extra support and coaching from a peer perspective and catching people doing things that are good, that's another thing that we talk about, is really important. And that type of leadership within and just people that are right there day to day, minute to minute, is incredibly important. So while that top oversight and guidance, like setting that expectation, is really important, it's also important to set that expectation among peers that, no, we're in this together and we're here to do the best we can for the people that we're serving.
I'm curious, folks in the audience are likely feeling energized about creating trauma-informed environments for their service recipients. I wonder if each of the panelists can just in their mind, or just kind of share 2 or 3, because I know we're running short on time here, 2 or 3 kind of basic steps on this path for creating a trauma-informed environment in their organization. Anybody?
Well, I think the first thing, and I think we don't do enough of it, the first thing is we have to really understand how much trauma there is in our population and what it looks like, and really to identify it. I don't think we're there yet, and I know we're not in the mental health field, so all the staff need to understand that when these kinds of things happen to you, this is how you tend to behave, as opposed to you're a bad kid or you're an oppositional kid. So I think if we could get the whole field to really understand this and learn how it integrates with psychiatric symptoms, I think that's the first step. If we don't do that, we can't create trauma-informed environments.
I think one of the most important things that staff have to do, and I think everybody has to do, is do an emotional self-assessment of themselves and ask themselves the questions: am I emotionally prepared to be able to deal with these kinds of situations? We are going to face challenging situations and challenging behaviors. We are going to face disrespectful behaviors. We're going to probably face aggressive behaviors. And I have to ask myself and prepare myself with the ability to stay calm, objective, and respectful, despite the fact that I may be dealing with some very difficult situations. That's easier said than done, but it is doable. And I think Stephanie talked about a little technique there where you say, when we support one another in that camaraderie, and when I recognize one of my fellow employees perhaps is becoming a bit emotional in a situation, I might be able to tap that person out. I might be able to get them to go take 5 themselves, go do some sensory modulation for themselves to get themselves back into operation. So that's where I think is really important if we're going to be successful in the trauma-informed environment.
And I think too, like really making sure, again, to echo the importance of that our problems are due to real causes, and the trauma-informed care aspect of moving from, what's wrong with you to what happened to you is key and definitely worth noting again. And also that medication is a tool, not a solution. And, I think a lot of times just in our society as a whole, it's like, oh, they're off their meds, the meds, and everybody focuses on the meds with mental health recovery. And the fact is that that's not, research shows that just meds alone isn't going to fix any mental health issues. It's really that
Particularly,
work.
particularly this one.
Yeah, and I was
Because
really grateful that you said that.
There is no medication
I'm-
for this.
Yeah, and a lot of us spend time like, I would have panic attack after panic attack, and it would just be upping my dose to the point where I was so medicated I would pee my pants, and which has never been a problem before or after that amount of medication. But really, what helped me was learning the self-help tools of how to breathe, how to stretch, how to meditate, how to self-center, and really understanding that those self-help tools are the long-term recovery tools that people need, and to open up their minds to recovery is real as well, and that it doesn't matter if you're diagnosed with schizophrenia or anything, that recovery is real and possible.
I want to thank our panelists, DeMonica, Stephanie, Dr. Havens, David. I want to thank you all. I also would like to thank Laura Mandel for putting this webcast and event together today. And Diane, I'm going to turn it back to you.
Yes, thank you, Tricia, and I want to echo your thanks to all of our participants today, and Laura as well, those of you who are here today, and all of you who joined us via the web. We really appreciate your participation. And one of the things I would ask of you is if you did join us over the web today and you could send us an email address to our address at forum@opwdd, that would be very helpful to us. We're trying to build a distribution list, and the technology that we are using today for this webcast does not record the viewer's email when you log in. So it would be helpful to us if you could let us know that you took part today. Also, we welcome any comments, observations, recommendations for the future. This collaborative among the 4 agencies that have put this together is very much a collaborative, and we want to hear from all systems, all participants, all stakeholders on what we can do to move forward this restraint seclusion initiative. So with that, again, thank you to everyone. We appreciate your participation, and we look forward to our next event. We will send out information on that via email as we have our next one planned, and have a great afternoon. Thank you.